Okay, so I know the CTO session, so and I'm talking about the new era should be coming with the CTO, the DCB using in CTO. I don't have any conflict regarding this talk. So as we all know that intervention cardiologist era starting with the balloon, and I hopefully it will end up again with the balloon. So when we do talk about the CTO, we always want to go with the minimum residual stenosis and stent re-occlusion rate should be low. So this the prototype of the drug-eluting balloon when we started, and we know that it's a little bit bulky, but the idea is phenomenal to end up without any stent in the vessel when the scaffold is filled. So I think the future of the intervention is going with the scaffold drug-eluting balloon, and I think Dr. Colombo and the Italian team have been aggressively progressing this field when they start to do a PCI with without any stent and without put any metal and avoid this prolonged or long stenting implantation in the artery. So still our area to leave this kind of stent, as we see here the histeromorphology of the stent when we take it, and we see the stent and the any stent proliferation and the in-stent restenosis rate is high, and how it's doing the histopathology, the artery, when we put the stent and the in-stent restenosis when it's coming again. Of course, with the TTO, it's this is should be increased, and when we take the same inhomogenic drug distribution of the drug of the balloon when we put it to the artery, so the balloon extend the drug over the balloon and put it to the stenosis segment or the disease segment, and this will decrease the instant restenosis and new internal proliferations again. Of course, we have a paclitaxis and the sirolimus drug-eluting balloon, which is starting in market, and I think the paclitaxis has been showing superiority so far over the sirolimus drug-eluting balloon. So the rule of doing the drug-eluting balloon in TTO is still limited to the small vessel disease. And this, if we see this picture, when we go to the glasses and we try to go inside the glass, always we injure, or we injure ourselves or injure the glass itself. And this is the same imaging as when we deal with a small vessel. Post CTO, negative remodeling, very small vessel. Stenting, we don't know the actual size of this vessel, and we start to put a lot of metal, and we end up to have any stent restenosis or stent occlusion, acute or subacute or late stent thrombosis to this kind of CTO segment, because we still don't achieve a well proper size to the artery, because we cannot see it even with the IVUS, the negative remodeling distal vessel, we don't know the proper size, especially in the LAD. Still all under studies, and we need more studies in CTO using the DCB. When we talk about CTO, we have to have the algorithm. The algorithm, I think our colleague has been mentioned this algorithm before, doing better angio, CT scan, IVUS guided. Dr. Carlino here, thank you for Dr. Carlino to have his techniques to modify the proximal cap if we have an ambiguous cap, and then retrograde, antegrade, the ADR, all the technique of CTO we have to mention. This scale has been mentioned in Euro intervention for the instant restenosis strategy for DCB. Using DCB, have any stent restenosis, consider IVUS or OCT to see the mechanism of stent failure, and then start to see which one the failure, and the well preparation of the artery guided by OCT and IVUS with achieve the residual stenosis of less than 30% and DCB implantations for 1 minute. This is a strategy for instant restenosis. What about the CTO? So this was instant restenosis, and this is the start, this is the result. But our strategy for CTO. Hey, CTO long lesion, distal small vessel, side branch, consider DCB. So this is our strategy in our centers. We do this. So if we have any long lesions, we just stenting the proximal segment, and this rest of the segment should be with DCB. Distal vessel less than 2 millimeter or less than 2.25 millimeters, we don't use any stent. We put DCB. Any side branch in CTO less than 3 millimeters, we should be considered DCB. And of course, IVUS and the OCT is mandatory to use the proper side one-to-one DCB and well preparation of the artery before we start. Well preparation means black atherectomy or high pressure balloon or shockwave if you have, to achieve residual one-to-one less than residual stenosis with less than 20%. If you have a non-flow limited dissection, even we don't care. If we have a good flow, we will apply DCB, and that's it. And in the follow-up, patient doing great. And I think Dr. Colombo has shown a lot of case using the rotablations and both the DCB and this with a good result in the future. So DCB intervention, balloon 1-to-1 or 0.8 to 1 for high nominal pressure for more than 30 seconds, and sometimes for 1 minute or more. And well preparation of the lesion, as I told you, and finally the DCB is the final get. And this is one of the examples of the small vessel distal RTA, and this is the final result. I would, and here's how it's the artery and after 2 months. And again, if we have the calcium, always put a stent in distal vessel with a high calcium burden. Always it makes us trouble, and the stent failures is always the result. I give you a quick example of a female lady which has she had 53 years old with the body mass index of 24, risk of diabetes, hypertension, and he has a multiple PCI with a multiple stent failure because of very heavy calcification. And here, so sorry, this is why it's not working. So she has an occlusion of the LAD from the ostium. I don't know why it's not working. Here's the federal XCR was passed good. I don't know why the previous image is not working. So here was the lesion. I'm so sorry for some technical of my computers don't appear the first image, but she has a very small vessel disease, hyper artery in LAD, and this was successfully opened antegrade with a federal XTR. And then we release dilate, and we put the stent proximally, and here the distal LAD was implanted with drug-eluting balloon successfully. This was all in stent restenosis. And here finally the artery. After we open the artery. This is after DCP. It's a small vessel disease. This is the final result. I'm so sorry for the first image is not appeared. I don't know why. But this is the final result. And this is an example of what we should use the DCP in this vessel. So to conclude, through the clinical data supporting that using of DCP in CTO lesion is still limited, initial advanced detailed clinical practice and solved a concept point towards a synergic hybrid treatment strategy based on combinations of DES and the DCB to reduce the total stent length and still maintaining the scaffold probably in the DCB where be mandatory, especially in complex intervention. Once trial will evaluate the DCB for distal portion of the CTO, will be spot stenting in the proximal, as I told you, and then we put the DCB for distal vessel. Finally, DCB is only approach in CTO management of antegrade human-to-human wiring possibility, but larger study still needed. And I hope in China, this study is going on. I know you're doing a lot of distal left main bifurcation single stent strategy and bifurcation DCB is going to randomized trials. And I hope we participate all together, the CTO operators, to reduce the stent implantation in the CTO segment. Thank you very much.